Thank you all very much for being here today, for taking time out of your busy schedules. My name's Jim Baker. I'm Chief Medical Officer for Integral Care, and I'm going to be doing the introductions this afternoon. But again, my thanks to each of you for being here. I'm deeply grateful for your interest in understanding this persistent problem about addiction to pain medications and addiction to heroin. And, you know, I'm sure if you're like me, you've thought a lot about why the huge uptick in addiction to pain medications and, you know, why nationally it's up to about 30,000 people dying of overdoses each year from pain medicines and heroin. And I recently ran across an explanation that I thought was fairly powerful, and it was in an unusual place. It was online, but it was in a business magazine of all places. And it was a business magazine that was talking about talking about the problem with the economy in West Virginia. And it was about how the pain medication use in West Virginia has increased exactly in parallel to the unemployment rate in West Virginia as coal industry jobs have gone away. And it occurred to me, thinking about it in a different way, that in a way it's the painful lack of jobs in those communities that was driving the pain medication use. So it was the sort of pain that's being addressed in a poor way. And for me, it put the problem of addiction just generally into perspective, that the rise in addiction to pain medications reflects the pain and suffering in our communities where there are other problems like not being enough jobs or just the pain of families struggling to make ends meet. So for me, the solutions for substance use problems like the pain medication addictions isn't just with substance use services alone. It comes from assuring that there's enough jobs, that there's a livable wage, that there's affordable housing, that there's support in the community for families where everybody in the family is having to work, and that there's also access to good medical care so that a small problem with a little bit of pain doesn't turn into a large problem requiring chronic pain medicines. Today, we're fortunate to have with us some experts on the issue of abuse and addiction to pain medications and heroin. And I got to tell you that the folks on this panel have been my inspiration in many ways to start more zealously advocating for adequate substance use services in our community and our state. And so I'm delighted that they're here to nudge on you the way that they've nudged on me. First of all, we'll have Dr. Jane Maxwell speaking. She's an internationally known expert with the Addiction Research Institute at the University of Texas School of Social Work. Her research is on trends and patterns in substance abuse, and her work's cited both nationally and internationally, and she's the author of the annual Texas Drug Trends Report. After Dr. Maxwell, we'll have Dr. Bill Lawson speaking. Dr. Lawson is the Associate Dean for Health Disparities at Dell Medical School. He's a colleague of ours at Austin Travis County Integral Care, and he's also director of the Joy Anderson Community Health and Wellness Center at Houston-Tillotson. He's the Emeritus Chair of Psychiatry at Howard University. He's a national expert and research leader in mental health, substance abuse disorders, and on disparities in healthcare research, particularly in mental health. I've been watching him since he's been in town. He's had a huge impact already. He's had a huge impact on me. He's had a huge impact on our community's leadership's perspective on how to address substance use just since he's been here at the medical school. And then Mr. Mark Kinzly will be the next speaker. Mark's an expert in harm reduction and public health. And I have to say that Mark's voice is in my head almost every day from his passion and his persistence in making sure that there's a voice for folks with these opioid addictions and people at risk from overdoses. He is co-founder of the Texas Overdose Naloxone Initiative, and he's on the board of the National Harm Reduction Coalition. So first, will you just join me in welcoming these folks here to speak? But our speakers won't be the only ones talking today. There will be an opportunity for you to ask questions and express your opinion. And during that part of the forum this afternoon, my colleague at Integral Care, Ms. Louise Lynch, will be moderating. And I want to thank you for doing that as well, Ms. Lynch. Again, thanks for all of you. Thanks for attending today. I'm hoping that our speakers will have the same impact on you that they've had on me, and that will be for you a call to action for advocacy, not only for substance abuse services, but to share information, to reduce stigma, and to help make treatment more available for people in need in our community. But I also hope you'll leave the forum thinking more broadly about the substance abuse problem, and that it will stir your advocacy not only for better treatment and less stigma, but also for better jobs, better housing, and better access to quality of medical care. So without further ado, Dr. Maxwell.
Thank you. Let's talk about what's going on with heroin. And you have to excuse me, but I'm going to have to turn my face away from you a little bit just so I can make sure I'm on the right slide. One of the things we need to think about is not just heroin, but the role that these other opiates play in driving what we talk about a heroin or an opioid epidemic. A lot of the literature is very unclear. Did they start with heroin and shift to pain pills, or did they start with pain pills and go to heroin? General consensus is they started with pain pills and went to heroin, but you've got some evidence going both ways, so that interrelationship. In Texas, we have the Holy Trinity, the Houston cocktail, that is very much being driven by alprazolam, Soma, oxycodone. These are the pills that are easily available. We've had some success with the prescription drug monitoring programs and shutting these pill mills down, but the numbers are still far too high. And if you start on those and you can't afford to get more oxycodone, you're going to switch to heroin. Or if in the process of cleaning up the pill mills, if the doctors get a little bit scared about writing more prescriptions, they'll quit doing it, and that sends you to heroin. We did find in Florida, when they shut down a lot of the pill mills, it increased the heroin use. So it's very much a double-edged sword. You shut down the pill mills, heroin's going to go up. So we need to be aware that there are all sorts of different aspects to this. One of the interesting things is that finally FDA is requiring hardened oxycodone pills, harder to get to, harder to open. And read one wonderful article where they took some active users, gave them the old oxycodone that was easy to use, then the hardened oxycodone. It said, go at it. Here are hammers, here are pliers. If you can use it, take it. So they beat around on the hardened pills. They tried to dissolve them in water, which all that does is turn it into a Jell-O. Well, you can't draw up Jell-O and inject it. And they finally got frustrated and said, it's not worth messing with. I want to go back to the old pills. And, oops, I'm sorry. And we know that heroin is cheaper than any of these pills, but we also know that if you've got some old oxycodone in your medicine cabinet that's not hardened, you'll get more for it than the hardened kinds. So people are still seeking out the old remnant that's very easy to crush and snort or easy to dissolve. I want to talk a little bit about heroin and where it comes from. We actually have 4 kinds of heroin in the world. We have the Southwest Asian that comes out of Afghanistan. A lot of it traffics through Africa into Europe. This is the heroin that when you read the old movies about heroin. Trafficking. Most of the heroin in Europe is the Southwest Asian. We have the South American, which particularly traffics into Newark and New York City. We have the Mexican, which goes to Hawaii, and of course comes to Texas and up the West Coast. And then there's Southeast Asian. This is the old China white that was very common in the Northeast up until about 1983, when the South Americans figured out how to make white heroin. And it was like when Walmart comes to town. They hit New York City, they were selling it cheaper and in greater supply than you could get the Southeast Asian, and within a year they literally drove the Southeast Asian out of New York City. So we don't see Southeast Asian. There's still white heroin around, and people talk about Southeast Asian, but I think they're getting confused about what it really is. And this is what it looks like. Here's the Mexican black tar heroin. Gummy, looks like roofing tar, or it can be hard. That's the Mexican black tar heroin. We also have, now would be the brown heroin, but this is also what Southwest Asian looks like. We were very concerned when the Iraqi war started that we'd see a lot of Southwest Asian coming back. If you remember in Vietnam, we had a lot of heroin addiction in Vietnam. And actually, if you really want to know, most of the methadone programs that have been around since 1971, 72, were started by Richard Nixon in reaction to the heroin epidemic that the soldiers were bringing home. And that's really the first time we see the proliferation of methadone programs being funded. Then we have the Southeast Asian. Here's the white heroin. Most of it is the South American, but I'm beginning to hear more and more that the Mexicans are trying to create a white heroin that looks like the white heroin that comes from South America, so they can start taking over the market. And sometimes you read the paper about white heroin, and whether it's Mexican or Southeast or South American is a question. We also have the Southeast Asian. We haven't seen Southeast Asian in many, many years here. It feeds up into Vietnam, into China, and to Australia. One thing about the white that's important right now, we're hearing a lot, reading a lot about heroin being mixed with, let me see if it's on the next slide. Fentanyl. Yeah. And what's interesting, up in the Northeast, it's being mixed with the white South American. And so you're strengthening the potency. And one of the best stories that I think needs to drive through this is when you get addicted to heroin, from all the interviews I've done, they talk about, I can control it. I only did it on Saturday nights once a month. Then it was Friday and Saturday nights. Then it was Thursday, Friday, Saturday. Then it was every day. And I woke up one morning, I was so sick. I had the worst stomach flu I've ever had. I couldn't go to work. I called my friend and said, I can't go to work, I'm too sick. And he laughed at me, and he said, yeah, you're addicted. You got the malaria, you got the sickness. And the only way you're going to get rid of it is to take more heroin. And so we need to think about, with addiction, particularly with heroin, it's not just getting high, it's your main concern is where's that next dose coming from so that you don't go into withdrawal. And then if you can get a dose that's strong enough to get high on too, then you won't go into withdrawal. So a lot of what's happening with the mixing of fentanyl is to get a more potent high than you would get just using heroin by itself. Now, we had 2 deaths that have been reported, if you've been reading the paper, about fentanyl this weekend. And the medical examiner, and I talked about it, they're doing the analysis now as to what it is. But it clearly was not the fentanyl patches that we've always seen in Texas. It's not the lollipops that are used for pain. It was a white powder, which is not a pharmaceutical grade of fentanyl. It's being made probably in China, maybe in Mexico. 5 years ago, the Mexican road chemists were making it. And so it's being, in the Northeast, being added to the white heroin. And they say it's another one of those confusing messages. Public health, beware of heroin, it's got fentanyl in it, it's going to kill you. At the same time, that's going on, which sounds like what we say here. The people who were using heroin were lined up in the dope house to get more because it was more potent. Same thing I've heard here in Austin. What do you do about an overdose? Are you worried about it? No. if there's been an overdose, that means there's good heroin over in that neighborhood, and we hop in the car and go over there to see if we can score some. So we're talking about two different mindsets, keeping the sick off and seeking more euphoria. And this is the latest data on heroin in Texas. These are the Poison Control Center calls. They're slowly going up. These are the DISH's treatment data. This is the analysis from the toxicology labs. They're increasing. And this is deaths. Now, compared to methamphetamine, these increases are not that great. So I think luckily we're still in a fairly stable holding pattern. If a lot of these fools start messing with fentanyl, it's going to change things very quickly. But in Texas, so far, it's a problem that we can do something about. Treatment and preventing overdoses. So it's not out of control like it is in the Northeast. Deaths in Texas are getting younger and younger. Average age is now 36. It used to be 40. So we're seeing a younger population. And this is looking at heroin deaths in 1999 versus 2014. In 1999, the average age, the yellow is the rates in 1999. Look how much lower they are than the blue rates now. But the population most likely to die in 1999 were 40 to 44. Now it's jumped to 25 to 29. So they're much younger now. And that just confirms it. Now, it is in a comparison. We need to talk about all the other drugs other than heroin. Again, 1999, much lower than now. But in 1999, the oldest population was 35 to 44 and 45 to 54. Now they're much older. So you're literally jumping a couple of decades either way, younger heroin, older prescription opiates, and some speculation that this is the group that first started doing drugs in the 1960s in that generation, the Summer of Love. And maybe they were more likely to use drugs then, and now that we're all old and our knees hurt, more likely to borrow a pill when it's offered to us. But real changes in population, which has real importance in terms of targeting your treatment. Who are you going to treat and what sort of thing? Are you treating young people or are you treating old people? The population has changed. It's more likely compared to 1992 in Texas, more likely to be white, but it's dropped somewhat with the opiates and synthetics. So again, changes in population. Gender, heroin, 60% male. The other opiates, only 40% male. These are your women, and we kind of ignore them in terms of addiction medicine. But certainly there's a problem. And this is looking at mortality rate by year. Clearly, the blue, more men are dying, the rates are higher than the women, and particularly the last few years. But again, the women going up and the men. So more populations to deal with. And then in looking at poisoning deaths in the U.S., here is heroin, and you can see it's skyrocketing right up here. Here are other opiates, which would be, come back. Oxycodone, hydrocodone, methadone. Methadone has an interesting picture. It starts up, it plateaus and drops. And the reason is methadone, besides being a treatment for narcotic addiction, is a very good pain pill. It's really cheap. It's always on the formulary. And often in the past, doctors were encouraged to prescribe it because it is cheap. Now what happened, they started prescribing a 35 milligram diskette that was meant to be used in methadone treatment programs, but they were using it to treat pain. And a lot of the physicians didn't understand that you can't just go from hydrocodone to methadone. It's not a one-to-one ratio, that the methadone lasts much, much longer. So if I put you from one hydrocodone onto one methadone at the same rates, I'm going to kill you. But people didn't realize that. So the pharmacist, the company actually took it off the market right here and only made it available in narcotic treatment programs. So you can't get a 35 milligram diskette from the pharmacy anymore. So you've got the drop there. And then this is other synthetics. It's a strange combination. They really don't define. But this is your pethidine and this is your fentanyl. But you can't break out, is it really fentanyl or is it just that category? But again, the change. Okay, that's what it looks like, US. And here's Texas. Fairly similar, although other opiates has dropped slightly, but look at your heroin going up. So we look pretty similar to the national picture. Poison control cases. Hydrocodone, oxycodone, they're down somewhat. In Texas, the drop, same thing, except for the increase in oxycodone. So it changes around in the poison case. This is seizures of drugs that have been examined by DEA lab. And here's heroin, that's the big one. And then in Texas, you can see the same problem. So we look very similar. And this is looking at treatment. This is buprenorphine pills being distributed. This is from the manufacturers. This is the mono product, which it doesn't have the Suboxone. We don't tell people this, but the single product you can inject. So we don't really push that. But as another indication of another drug. Methadone, look at this. The numbers don't change. Now, we've been in the middle of this epidemic, but since 2002, no increase in the number of methadone programs, or very little. And here's the beginnings of naltrexone. Now, these are the naltrexone pills that aren't the 30-day shots, but these are the pills you can get. And a lot of them are used for alcohol treatment, but these are this is used for drug treatment. So what? Well, from the National Household Survey, almost 1.5 million said they were receiving medication-assisted therapy. Almost 4.6 million were dependent or abused. So we've got 3 times the number of abusers and dependent that we have space for treatment, which is one of our critical problems. And lastly, I want to show you a couple of things. Heroin is influenced very much by where you are in the country and the desire for a better high. The strong relationship between shifting heroin and opiates, and the need for more treatment, and the need to tailor treatment to meet the characteristics of the people today. They're not as old as they were 40 years ago when the methadone program here started, and I've been in it many times. They don't even look like those people anymore. So I keep thinking, what if you had methadone programs across the street from some of the malls, where you're purposely trying to attract the young users where they would go. But you'd get the not in my backyard kind of syndrome, but it would be interesting to think about where you would put methadone programs or other drug treatment programs where you were trying to attract the users based on their characteristics today. And then I want to show you, this is a county by county map of the bluer it is, the lower the mortality rate, the redder it is, the higher. So we start off this, and you first get Appalachia. Okay, that's 2000. 2001, 2002, New Mexico. This is that county that has been a heroin center forever, but look at your Appalachia. 2004, more Appalachia. 2005, and now you're beginning to see 2006, it just gets redder and redder at Appalachia. 2007, 2008, there's something going on the Oklahoma-Texas line. I don't know what it is, but maybe living up there you do heroin just because you live there, but it makes no sense. I guess I should be more serious about this. 2010, look at this. 2011, and here's your Florida epidemic. 2012, 2013, 2014. Now, a new population. Look at this. This is the Gulf Coast. This is all Appalachia. Then you've got that poor Texas, Oklahoma, all the West. And this is the latest data for 2004 on the death rates. Nueces County has the highest death rate of any county in the state. I don't know why, but Mark Kinzly, you need to go to Nueces County and fix what's wrong with
We'll
it.
be there in a couple weeks.
Good. And Travis County, in comparison, is lower than the others. But this indicates the high rates that we find with this. And that's how you can find me. And my apologies for not doing well. And Dr. Lawson.
Now, let me see if I can see this. Yes, I can. I'm going forward. So I'm talking about opioid abuse. One of the points that I think is key is that when I came here, which was back in July, I was told that opioid addiction was not a problem in Texas. So I said, doggone it, all my skills developed in the East, Northeast is now irrelevant. So thanks to Dr. Maxwell, I am now re-embodied with the value of this. I'll go over quickly some of the things she's already, talked about. And again, what are opioids? They are medications that relieve pain. They reduce the intensity of the pain, but they can also be used for other things too, such as relieving cough and severe diarrhea, i.e. Codeine and Lamictal. And this is just showing you that these are naturally occurring products from opium that they can be manipulated in various ways, made to powders and all kinds of ways. In other words, if you want to get opiates in your body, you can have multiple ways of doing it. One of the other classes, and these are some of the drugs that we already talked about, hydrocodone, oxycodone, morphine, codeine, heroin, methadone. I've had a number of patients coming in and say, well, I had a heroin problem, but now that I'm on codeine, I don't have to worry about that anymore because that's not an opiate. I was amazed at the number of people that do not realize how these problems are. I'm not going to go into detail about the problem that's already been stated. I think the main point is that U.S. providers wrote 259 million prescriptions for painkillers, enough for every American adult to have not a pill, but a bottle of pills. So there also reports that, again, 46 Americans die every day from overdosing. So we have a medication that's clearly widely available, but that also is toxic to people. Is it that toxic? Is it that dangerous? Of course, relatively speaking, you have to look at it. I remember when we talked about looking at the research in Valium and benzodiazepines. If you look in the animal work, you find that these agents are not very addicting at all. But they're so widely used that we're talking about a lot of people. who can get addicted. And so same way with opioid agents, many people don't get addicted. They never get addicted, they never have problems with it. But there's so much of it that just by chance, some folks are going to be having a problem. And we mentioned that these agents are used for pain relief. That's great. But they also have another side effect, euphoria. It's interesting. I sometimes have some of my patients on THC, the active ingredient for marijuana. And if you look at Marinol and you look at the package insert, it says, be careful of high doses. It can cause euphoria. So, again, that's a point that many folks forget. It can kill pain, and it's already noted. Folks who get addicted sometimes want to avoid the withdrawal symptoms. But the bottom line is it can cause euphoria. And we have very good research showing that almost all of these agents have antidepressant properties. So that's an issue that's often never discussed, but it's, and in fact, the FDA, NIDA was National Institute of Drug Abuse, was actually considering seeing if we could look these products up and make them into an antidepressant. Well, that didn't go very far. But again, that's also another factor to consider, because once folks get on these drugs, sometimes it's very hard to get off. Who gets addicted? I just threw up a couple of names up here. Some of those are well-known. I won't go into any detail, except that does not seem to show race, ethnic, income, status. Historically, it used to be jazz musicians, then poor people, and now it's all over the place. Oops. Just again showing that young people use it, as already stated. I won't go into detail about that. Associated with overdose fatalities in Texas is already well stated. And again, not just the overdose, not just the death. We need to look at this as also that in addition to changes in the brain, we recognize that it's an important vehicle in terms of certain chronic diseases, especially HIV/AIDS, hepatitis C, has economic impact. As we speak, there was a wonderful drop in crime and murder rates around the country and inner cities up until very recently, and then there's been an incredible spike. And a lot of this, of course, is drug abusers fighting over turf. And this is not a deep, dark secret that the recent riot in Baltimore, right afterwards when they broke into a CVS, that the murder rate spiked again because folks got free use of Oxycontin and other drugs and went out and fought over it. So it has an impact in terms of the economy as well as social characteristics. Folks do end up homeless from these agents. In addition, they end up in crime and also associated with violence. So the drug itself doesn't make people violent, it doesn't make people homeless, but the consequences of being dependent has important factors. And then HIV and hepatitis, the HIV epidemic is now not discussed anymore, it's recognized as a chronic disease, but it's still there, the rates are still constant. And the key thing is IV drug use is a key factor, but also the use of it in terms of an addicted person increases the risk as well. And then more recently, we found that a number of people, especially those groups from the Love generation, developed hepatitis C, and also they didn't screen as well. And now we're finding that the death rate from hepatitis C is now higher than the death rate from HIV. Again, directly related to, if you want, the opioid problem. The old question is, why do some people use drugs? We already talked about it, to feel good, the euphoria, but then again, the point that's already made, once people get on it, to avoid the bad feeling that you get when you get off it. So I won't go into the term of addiction, chronic relapsing brain disease, and I just want to emphasize the question of chronic relapsing. For some reason, for a long time, folks didn't recognize this as a brain disease. This was a characterological problem. People were bad, it was sinful, so forth and so on. We now recognize that this is a brain disease, and that these drugs change the structure of the brain, what it does, and it has long-term behavioral consequences. We now make a distinction between dependence versus addiction. We used to say that dependence in and of itself was a sign of addiction. You can become dependent, i.e. you can have the physiological changes related to tolerance and so forth after using these drugs without in any way wanting to use the drugs themselves or wanting to show drug-seeking behavior. And that's an important distinction. But what it also means is that you can have people who are otherwise fine, great, as long as they've been able to detox off these drugs in a reasonable way. But often, otherwise very responsible people discover that if you stop them, you don't feel good. And so that creates a dilemma. And I've had a number of patients come to me and say, "Doctor, am I dependent if I've used this?" I said, it's a physiological change. Dependence has nothing to do with your willfulness to use the drug. It's something that happens to your body without any kind of conscious anything. And that's an important factor to recognize. So again, I want to come back again to this issue about what do the drugs do. The drugs take over different brain circuits, and they take over those that determine your motivational priorities. How do they do this? Well, first of all, these drugs are important in terms of different brain areas that are related to normal motivation and behavior. You got to look at all of these areas if you want to do anything to treat or address the problems. You got to look at the frontal lobes in terms of adjustments. You got to look at the limbic system in terms of the pleasure sensation. You got to look at the motivational areas in terms of the brain itself. All the drugs of abuse target the brain's pleasure center, part of the structure of the nucleus accumbens, dopaminergic dependent area. This is also the part of the brain that you get pleasure from eating, drinking behavior, and so forth. So if you have a natural reward system that normally elevates dopamine levels, food, dopamine level goes up, sex, dopamine level goes up. This is what happens normally to people so that they get pleasure from doing these activities. What we know, though, is that in addiction, the key dopamine receptor, D2, is lower. So it's affecting those same brain areas, affecting the same area that's involved in reward and pleasure. And many heroin addicts will tell you the appetite's gone, the partners will complain they're not interested in sex anymore. The drug itself is taking over those brain areas. And the effects on these drugs, all of the drugs are very similar, although there's cross-reactivity, there's also some specificity, but all of them do affect these kinds of dopaminergic systems. Morphine, cocaine, amphetamine, all of them. Oops, did we lose it? Here we go. And again, this is just showing you, this is a synapse, showing you the release, postsynaptic area, dopamine release to what we call a dopamine receptor. That's the site of action of these drugs. And the chemistry is described as a central disease. It's an opiate addiction results from prolonged use, which leads to damage of the sensory nerves, which causes cells to stop producing an endogenous opiate called endorphins. It's not producing it anymore. And so these painkillers and the non-opioid abusers stop playing by blocking the nerve perception, now they're destroyed, and so the normal person simply doesn't perceive pain anyway. Prolonged use will result in inability of the body to cope with or stop pain. So in the long term, folks lose the ability to cope effectively with pain when they've used these drugs intensively. So when the drug is gone, even though the offending agent is gone, there's still brain changes that's occurred that persist in the ability, the need for the drug to deal with pain. This is the site of action. These affect a certain receptor called the mu receptor, which is very, very crucial because it is the one that's sort of opioids. There's also a kappa receptor. We now know that may be important in some of these agents, but key is the mu receptor, which is tied in with dopaminergic activity. Oops. So it's, again, I want to note it's a chronic illness, relapsing, people say, well, you're cured, going through detox, and you're cured. Not the case. Detox is helpful, but it's not treatment, because this is a chronic problem. The relapse rate, not that much different from when you treat a whole bunch of other diseases, diabetes, hypertension, and others. A lot of folks said you can't treat these, treatment is not effective. Not true. Just that our success rate, not that much different from other chronic diseases. This is just showing you the DATO study, the APOS study, just showing that, showing a whole bunch of treatment modalities, all of them work. Same way with yet another, the Delaware Work Release Therapy Program, again, showing a variety of modalities, showing treatment addicts, all of the treatments work. So we have a variety of treatments, and they do, in fact, work. Sometimes situations make it difficult to get treatment. Correctional system, for instance, it comes a critical setting in terms of maintaining chronic disease and also in terms of starting on new addicts for the first time. And one of the big advances recently is that introducing drug treatment in the correctional system. We always felt that you had to want to have treatment for it to work. Well, no. Sometimes involuntary treatment, even in drug abuse, can have effects. Introducing treatment into the correctional system has greatly reduced crime, reduced the spread of HIV and AIDS. The use of such interventions as drug courts, buprenorphine programs, and others have made substantial changes in terms of the spread of drug abuse in the community. We have non-medical programs, and they work. Cognitive behavioral therapy work, contingency management, motivational enhancement, family therapy. All of these interventions do, in fact, work. But many people, for whatever reason, either don't want treatment or don't particularly want it. So we have medication-assisted therapy, which doesn't require as much, effort, but the point is they are very effective in the, quotes, non-motivated people. With methadone maintenance, we've mentioned buprenorphine, some say it's the greatest invention in the last 25 years, perhaps, but it is effective. And of course, naltrexone, either given acutely to prevent death from overdose, but also there's a 1-month injection, which we found also very effective as well in preventing chronic use. Methadone therapy, well known, works very well. A colleague of mine who first introduced many of the programs, Beneprim, to the country, was adamantly against it because looked at a substituting one addiction for another, but then when they looked at the data, so that it really had a dramatic effect in terms of crime rates and in terms of addiction as an overall problem. One of the problems with methadone, of course, is you can use other drugs of abuse on top of it so that you may still be addicted and still use other drugs. Buprenorphine therapy, this was an agent that was developed as a partial agonist. Nobody knew what to do with it. It was an orphan drug. What good is it? It doesn't really block it doesn't cause the euphoria you get when you use methadone. It's a painkiller, but it's not that good a painkiller. What good is it? Well, what we found for it is that it is sufficient, not addicted enough, so you need all the infrastructure you need for a methadone program. Basically, it was promoted as something that can be prescribed out of a doctor's office. As already said, you can have a program where you can have someone, where you have the office right across the street from where the addict is. Recently, it's been approved for expectant mothers, it's been approved for 16 and over. So it's become an alternative that can be widely used. And it has some real advantages over methadone. Patients say it's safer. There's some question about whether or not you can use it for bad addicts, high-dose methadone. We've given mega doses and gotten as good a results as methadone. And it also has a much higher safety profile. There's still some debate about whether or not people try to kill themselves on it, whereas methadone and other opiates, respiratory depression is an important side effects. This is just showing you some of the key properties. It's synthetic. It's a partial agonist, less enforced and reinforcing, and more acceptable patients than an agonist, and easier withdrawal. And safety is extremely important. We found in the community that it's available in the community. There was a study in France that showed when it was diverted into the community, the AIDS rate actually went down. So it does have some benefits, not perfect, but again, because it's a partial agonist, what we find is that folks in the community, when it's used illicitly, it's often used to help withdrawal than it used as a primary drug of abuse. Again, reduces criminal activity. It also it reduces the acquisition of other drugs on the street. And most importantly, again, reduce acquiring drugs in the street. What we found is that, what we found is that in the street, where you find that people are much more likely to continue in counseling sessions. So it's important, not simply as a way of blocking the addiction, but also preparing people for continuing non-opioid treatment, which we've found is one of the most important uses of its use. It's not, any physician can prescribe it if they go through a waiver program, which has gotten made more available. Basically, I'll skip to this one, basically they can complete an online training to be able to prescribe a drug, get a special DEA number, and then they can prescribe. There's a limit in the US, it used to be 30 patient limit, but now increased that substantially. But still, there's a major problem in the insufficient number of providers. So there's financial barriers, the limited number of prescribers may also be a factor. So here's an effective treatment that is simply not as available as it could be. So going forward, a number of the organizations came up with some very important factors. One is that we need more healthcare providers to get opioid prescriber training. We need to double the number of physicians certified to prescribe buprenorphine. We need to double the number of prescribers who can prescribe naloxone, and we need to double the number of healthcare providers registered with the state prescription drug monitoring programs. And again, look at the number of organizations that are supporting that initiative. So we got a solution. We got to end the pack. We've got to do something for it. What's not stated, and I just want to emphasize again, we have pharmacological interventions, we have behavioral services, but we also must have medical and social services because many of these folks have ongoing secondary problems. Drug rehabilitation is extremely important. Some folks do not want to be on drugs for their life, and so we need to look at rehabilitation in terms of the recovery approach as a way to go beyond it. One of the controversial issues right now is I have one who's a minister who goes around and say, I'm cured, I'm on buprenorphine, I'm not a heroin addict anymore. But the recovery program said, no, you can't come in, you're still on something. So there's a whole controversy about what is recovery and what is effective. And that we can debate about that ad nauseum. Also, there are programs like Expert, where we're trying to do outreach to non-addiction providers to be able to treat them basic skills to be able to identify and address drug abuse, which we think is an effective method to deal with this problem. So again, we got to treat the whole body, the whole purpose, all of it. And so we're making some gains. Hopefully we can make an intervention that can be effective, not only just for the individual and not only for the family, but also for the entire community. Thank you.
Really appreciate Dr. Maxwell and Lawson's talk and what I'm going to talk about. So I was sitting there thinking about what I want to say here, and so I just need to let you know that oftentimes when I do these kinds of talks, and there's nothing that's more uncomfortable to me than standing in front of you guys. So I'm going to just let you know in the last 3 weeks, so I'm going to do this a little bit of piece of the talk for Bess Davis and for Ryan J. and for Zane, who in the last 3 weeks, all in long-term recovery relapsed and died from fatal overdoses. So what I'm going to talk about is at the ground level, what we can do around interventions. And so I think it's always interesting when I get the opportunity, in particular with individuals that have huge amounts of information around data collection and all that. But the most important thing for me, and I'll come back to this particular side, the most important thing to me is the human aspect of it, and I think that we stand in this room for that reason. I will tell you that this individual that's sketched on this slide is a gentleman that saved my life because he had access to naloxone when I relapsed after having 12 years in the recovery process. And the unfortunate thing is this is also the gentleman that I found in my office at the School of Medicine at Yale University from a fatal overdose after 15 years of being clean and sober. So the initiative that I'm getting ready to talk about is real personal to me in a lot of different ways. The information that was presented earlier is really critical, but I'm going to talk to you about what this looks like at the ground level from the community. And if I feel and sound passionate about this, I'm going to tell you right now, I'm not sorry for that, right? Some people can get agitated with it. It's New York, I'm sorry. So, you know, we started doing naloxone distribution and access in the communities, mostly around syringe exchange programs. And it says here, as a direct result of Dan Big from the Chicago Recovery Alliance, finding out what was being done in Italy and many other places around the world. What really drove this was Dan's best friend in Chicago, who he'd been working on the streets with for a number of years in syringe exchange program, who relapsed and died as a direct result of a fatal overdose. And it motivated Dan in a way that he started to talk about this in the avenues and arenas where active drug use occurs and people that engage with active drug users. And what we found was that the more information and the more access and the better education around the issues that drive people towards overdoses and getting the medication out there will save lives. We distributed our first dose of naloxone in the state of Connecticut and in New York City in 1997. I'm not going to get into how many personal rescues I've done, but there's been many. And the more trained people are, the greater access to this particular medication, which is pretty benign for, overall. And we'll get into that, just saves lives. We should be doing this everywhere. The service provisions that we currently use that are really an opportunity. There's a number of gateways where we meet people that we don't take advantage of the opportunity to educate and put medications in the hands of the people that we serve. And so we know for a fact through the data that Dr. Maxwell has been collecting for a number of years and a lot of other people in regards to the highest rates of overdoses, where do they happen, why do they happen? And let me be clear on something. Drug users are no different than any other consumer of any other product. We go get good drugs because everybody else that's a consumer also wants the biggest bang for the less buck, right? It's not different, folks. People do not go after drugs because it's killing people. They go after drugs because they're good, right? And so it's really important to know that when we educate people around some of the things that are fatally having fatal consequences to people, that there may be a rise in that area of access to that drug, right? But we also need to know that we need to be at the ground level educating people about what it looks like, right? I would like to, I really am encouraged, and I'll apologize to Dr. Carlos right now, so yes, we're talking about why people use opioids and things like that. Let me tell you, part of the reason that people use opioids we talked about in regards to physical pain, but let me tell you how it works on spiritual and emotional pain too. And untrue to what the great philosopher Nancy Reagan told us, they work. That stuff works. It's like the warmest blanket on the coldest night, I'm going to tell you straight up. okay? The reason people use, and the degradation and discrimination that Dr. Lawson was talking about in places where I grew up, like Bedford-Stuyvesant, New York, and in Baltimore, the reason people use drugs is because the situations around them are so degrading sometimes that the only relief that they get in the course of the day is with a bag of dope or a joint or whatever they happen to be using at that time. So I always wanted to tell Nancy about the just saying no issue is, you know what, Nancy, you've been on benzodiazepine for 40 years. You say no, we'll think about it. So naloxone, which is an opiate antagonist, and it has an enormous success rate with reversing the effects of an opiate overdose. And in layman's terms, and I'm not going to go through a whole lot of data stuff. I'm just not going to do it. So the way that it works is basically when the opiate is taken, it sits on the opiate receptor. What naloxone does is it's an antagonist that comes in between, in layman's terms, between the opiate receptor and the opioid and kicks it off. When people take opioids, it slows down the respiratory system, right? And in combinations with other central nervous system depressants, slow down, slow down, slow down, stop, right? So that's basically a poisoning. And naloxone, which has been around for about 60 years, being used with EMSs and other medical providers, is a really benign medication that really the only thing it's good for is usually saving lives, right? We put it in other medications like buprenorphine and things like that. But the major reason for this that is used today is to actually bring someone back to life, right? So what we do and what we've been able to do in a number of states throughout the union is that we've been able to pass legislation that makes access to naloxone more available. If you're here in Texas, there's a law that's on the books right now, 1462, that allows greater access to this medication. We've been able to obtain physicians that are in the process of writing standing orders so that people that have opioid addictions or are family members of people that have opioid use or addictions have access to a simple medication. So just like the opioids in their medicine cabinet, we should also have naloxone in their medicine cabinet. And we're certainly going to look at co-prescribing in the next legislative session. That probably won't go over well with physicians. So I don't care if you're on Skid Row or if you're at the Tower or UT. One of the things that we know for a fact is that this thing is not discriminating, right? It is now the leading cause of unintentional deaths in the United States, and it is getting worse in Texas. And I also got the explanation that Dr. Lawson got that, you know, we don't really have a problem here. Well, the interesting thing about that is if you want to practice really basic, really good public health, is that when you see something happening all around you and you don't think you got a problem, you might want to put stuff in place, right? And so whether it's at the Skid Row level or at the academic level, one thing we do know is that there's been a number of students that have overdosed. We know that folks on the street are overdosing, and we need to take action around this. So we train people. We train people on the streets. We train people in methadone clinics. You know, we've been training methadone clinics for the last 2 years here. There's been a number of reversals in there. People come in, and what we call it is, you know, how to recognize, how to respond, and how to evaluate an overdose, and what that looks like. And let me tell you, from personal experience, there are a few things that are more powerful than seeing a life come back into an individual that was dead. It's a powerful, powerful, powerful thing. Drug users are the most stigmatized population that I think there are. We're very misunderstood. You know, I appreciate the fact that Dr. Lawson talked a little bit about methadone, the most effective, appropriate, long-term treatment for opiate addiction that there is. How we do methadone in this country is insane. It's the only medication that I'm aware of that you got to line up like cattle, pee in a cup to get your medication. And so when we start to remove the stigma and the barriers to appropriate medicated assisted recovery programs, we will start to see the positive effects that has on the overall lives and the communities that they live and function in. So We do a number of trainings, whether it be on the street, whether it be with family members, of which, by the way, folks that are at the street level or family members are the major contributor to the reversals and rescues of opioid overdoses. We are 5% of the world's population, guys. We are 85% of the consumption of opioids in the world. It's crazy. We have an appetite for opioids like nothing else, right? And so the more that the demand continues to come in, and what Dr. Maxwell was talking about, the increase we're going to start to see in these synthetics like W18, these fatally, obviously fatal synthetic opioids that are coming into our communities. I'm from the Northeast. I experienced this. What you're getting ready to get handed in the state of Texas is not something you don't want to be ready for. Trust me on this one. And so we've started to look at distributing naloxone. When I first came here, there was no naloxone being distributed. Now we're doing it in some underground venues in 7 communities. A number of community-based organizations are now doing it. The Department of State Health Services, through their NAS program, is allowing us to go out and start doing overdose trainings to community providers around the importance of the education and access to the medication around this. And so I'm not going to go through more numbers. God, if I look at more numbers. So when we look at the medication itself, it's a pretty cheap medication that has become incredibly expensive. When I first started doing this in 1996, you could get a 10-vial dose of naloxone for $25, right? That same a 10-dose vial of naloxone now costs over $400, right? So we need to look at ways, because if we're going to get access to this medication into the community, it's got to be affordable. So there's a number of things that we're working on, that we're looking at. We need to go to some private funders, some philanthropy, federal funding. SAMHSA had put out an RFP recently where Department of State Health Services here in Austin is applying for that particular grant. A great portion of that grant will allow us to get access and pay for naloxone. We need to look at doctors that are willing to write standing orders around this. We do have a couple of doctors, some of which are in this room, that are willing, and some are going to write standing orders. We will have a standing order in place by the end of May for all Walgreens in the state of Texas, so people can walk in without having to go in their private doctors to get this. We get a lot of the naloxone. We've distributed right around 15,000 doses of naloxone in the state of Texas, with not one red dime coming from any funders in this state. We've had it donated from a number of community-based organizations around the country. We have documented, quite honestly, right around 552 rescues, and all done by lay people. About 85% of all rescues that are done in this country are done by lay people. And what I mean by that is family members, other people using opioids in the community, not by what we hear around first responders, right? First responders in the cases of overdoses are not police and EMS, all right? So these are just some more numbers. What we know is that there's a number of venues that we're starting to gather research, like Dr. Maxwell was talking about, and we're starting to really see the trend around this. This is being called the epidemic of our generation. And I'm going to say this will not be a popular remark, but I'm going to say it anyway. Thank God white kids started to die. Because in my community, for many years, this was happening. And the community that I come from in Brooklyn never got noticed or even attended to around this particular issue. I don't care why it's happening. I know that we need to take advantage of the fire while it's hot right now before we lose more people. So we need to get there's a number of matrices that need to come into place here in regards to education, access to medication, whether it be medicated-assisted recovery, methadone, Suboxone, buprenorphine, many of these medications. We certainly need to have naloxone in every cabinet in everybody's house in the communities, because this is killing at a greater rate than we've seen. The DEA, ONDCP, we had Michael Botticelli here last year. Texas is #2 in the United States for healthcare costs associated with opioid abuses. Do not tell me we don't have a problem here, okay? We may not keep track of things real well here. We got a problem. #2 in the country. We have 4 of the top 25 cities in the United States for prescription drug abuse. We have a problem in the state of Texas. We have a number of things in the process around interventions, educations, and if people want to get involved at the grassroots level or within your agencies, there's a number of things happening. Thank you, Dr. Baker. I don't know where you went to, but ATCIC is stepping up to the plate. There's a number of things in the process happening. People are really seeing the importance of this. This is a sister, man, that I'm really close to from New York City, who just delivered twins 7 months ago. And if you see what that, ooh. Like, thank God her boyfriend had naloxone, right? Right? Like, thank God, right? Because you ought to see these babies, right? Now, this sister's got over 3 years clean now, right? But thank God her boyfriend had naloxone, right? So, this is the reason we do what we do. And, there was some needless deaths recently. Fentanyl is not going anywhere, folks. I'm getting here to tell you. It's because of the appetite that the United States has for opioids. We're going to continue to see greater access, lower cost, higher purity, coming from clandestine laboratories in Mexico, Colombia, and all around the country. They're going to come in here. And if we stop it at the borders, guess what? We're going to start making our own, because it ain't going to stop. People will do this because this stuff actually works to some degree. So I hope that was somewhat useful. Thank you.
That was powerful. We have a very few minutes for some questions. And because we don't have a mic within the audience, what I'd like you to do is if you have a question, if you would just stand so I can acknowledge you. If you want to ask it to a particular panelist, that's fine. And yes, Dr. Maxwell.
Question for Mark, but actually I want to point out that I think we need to think about naloxone not only for young people using heroin. How many people, our grandparents, grandpa's on very strong drugs, he's lying in the recliner, he's a little bit confused, he can't remember when he took his last strong drug, and he takes another one and he overdoses. Every prescription for a strong opioid ought to be accompanied.
Absolutely.
Yep.
And that would change a lot of this perception about we're just keeping dirty young people alive. Makes a big difference and you read it on the methadone desk. People go into new methadone treatment, and the death certificate, he was snoring loudly. His wife heard him gurgling. He was dead by the next morning. She didn't know he was overdosing, and she didn't have naloxone if she had. So add that to the want list.
Great point.
Mark, do you have a response to that?
Well, I think Dr. Maxwell's right. I think that there's a couple of things we know that happen. So let's take some college students, for example, right? And then we'll go to the older population. So one of the things that occurs is people binge use, and so there's oftentimes a combination of drugs put in there. And one of the most common factors that we hear about is that gurgling or snoring sound. And what we call that on the street is the death gurgle, right? But in college, they think their friend is just really messed up and they're going to sleep it off, and they put them to bed and they never wake up. And so with the older population, one of the problems is that when somebody in their, I'll give you an example. My mother, who was 78 years old, bad woman, man, love her to death, right? had a minor surgery on her leg. My mother has COPD. The doctor never talked to my mother about the respiratory illness and getting an opioid and what that meant in regards to that, right? And it's not that the doctors don't want to do the right thing. You know, we need to start educating people. Respiratory illness, you're given a suppressant that slows down respiratory, so we need to talk to our older people. And when older people die from this, it's not put down oftentimes as a poisoning or as an overdose. It's put down as old age or whatever.
Yes.
Can you speak a little bit about what we're hearing about chest wall rigidity associated with fentanyl and an increase in fentanyl? Will we see more difficulty with performing rescue breathing with those who are overdosing from fentanyl, and then increasing for naloxone as a result?
I actually told Lisa to ask me that question. No, I didn't. It's not true. It's not true. So one of the things that Dr. Zabel at the CDC and a number of Dr. Alex Wally up at in Boston, who's been doing a lot of work on this, they're inundated with fentanyl up there. And one of the things, and Dr. Maxwell actually responded to this on the national list, one of the things that we're seeing is that people are having what they call wood chest or chest rigidity syndrome. And what happens is that their chest, it's almost like getting hit with Novocaine, their chest and their lungs freeze up. So even when we're doing rescue breathing on people, it may not be enough. Even with the naloxone, we have to teach people to get emergency medical people there in order to get them the medical help that they're gonna need, right? So not enough air. I don't know what the physiological effects are, Dr. Maxwell or Dr. Lawson, around why that's not happening. But what's going on is people are not getting air into them. In the Northeast, with the powerful synthetics that are going on, people are turning blue, and before they hit the ground after taking a shot of this particular drug, they're dead. And so we need to educate drug users in the community. Drug use, Dr. Maxwell's slide showed it. We're starting to see increases, guys. We need to educate the drug using community around what it looks like. Slow and easy. I know people are going to say, you're going to tell them how to use. They're already using. Slow and easy, right? We need to really talk to people about when they come out of jail or treatment, because the number one result of treatment is that people relapse, right? And so we need to be ready for that incident to happen. Dead people don't get better. They just don't get better. And so, yeah, anyway.
Yeah, I think one of the things that people tend to forget is they like to look at these agents as very simple agents where they cause a high and all that stuff. The bottom line is that many of these opiates, as I repeat again, don't just affect the mu receptor, they affect other receptors. They don't just have respiratory depression in terms of stopping the breathing apparatus. It also affects the entire breathing apparatus. So that a drug like naloxone, which is very specific, will allow some of the other effects of the drug to persist. So you got them breathing again, but you may not have affected some of the capital stuff and some of the other effects in terms of chest wall activity and so forth. And it's also important to remember that these drugs do have persisting effects. You did the naloxone, but you still may have some. I've seen folks who've gotten naloxone and then cured, well, saved, wonderful, and bang, gone again. Because again, he had persisting long-acting agent rather than a brief-acting agent.
And it's a really good point, because so naloxone only lasts 30 to 90 minutes, right? And so you have some of these longer-lasting opioids that sit back on there. People do go back into overdoses. It's important that we educate people about staying and evaluating people. The other thing is this, with the increase in fentanyl use, which has a very short half-life, the thing that opioid users hate the most is withdrawal. So at 2 hours, they're going into withdrawal because of the half-life of this. The drug has not left your system. The high effect has. They put more on top of it, more on top of it, more on top of it. And that's why we're starting to see some of the things we're seeing. So it's a multi-pronged approach that we have to take, guys.
Okay, up here first.
Hello. Okay. Lucas Hill from the College of Pharmacy. I just wanted to say I really appreciated everything that you guys shared, and I shared Dr. Lawson's sort of enthusiasm for buprenorphine. I wonder if you could comment at all about differences in the U.S. from how other countries approach it that limit use. The fact that while we allow physicians to prescribe it, we cap the numbers, we don't allow NPs and PAs to do it. In England, pharmacists are successfully doing this, administering these opioid maintenance therapies, and talk about putting a clinic in the community where patients are using this. There's a pharmacy in all of those clinics, and so is there any effort in the U.S. or any hope of expanding access through similar mechanisms? And also, could you comment possibly on observed heroin use and how that might fit into a harm reduction strategy?
Well, you're absolutely right. Other countries have done different strategies. When we first came out, we said, ha, this is salvation. Some countries, I had a patient that came from Germany. She came to the U.S. She said, well, I'm going to go out and give me some Subutex, not the one with the Naloxone. She wanted the Subutex. I went to the drugstore and they wouldn't give it to her. So what? In some countries, you can get it without prescription. And again, because they recognize very early role of harm reduction. In the U.S., we're working against an almost puritanical belief that if you have something that causes pleasure, you absolutely must not make it available. And again, we've tried to expand so that physicians wouldn't have to go through a huge training program. We've now got it so that you can go online and get certification. We tried to expand it so that you could have more than 30 patients, dance up to 200 patients, but it's still not enough. I have a client that has 500 patients because none of the other physicians will prescribe it. Why? Because we send out a mixed message. If we were told originally that it's bad for people to have pain, and so there was a big effort to make sure everyone got enough oxycodone and other medications so that you wouldn't feel pain. Now we're told that treating pain is evil, and so the tendency now is to look very careful to make sure physicians don't overprescribe. I've had 2 colleagues already who doing what they could to treat addicts with agents like buprenorphine, but who didn't keep group records and so forth, so they lost their certification, literally. So in the clinic that I had at Howard, we had a fairly extensive support system, but literally I got a visit from the FDA every month. They're nice people, pleasant. Hi, how you doing? What's happening? I said, what are we doing? We're not running some sort of pill factory, but the bottom line is that there's still a real problem in terms of enforcement, in terms of making sure that people don't get bad drugs, and the whole issue about what can you do to keep people safe because of the widespread availability of opioid agents in our community.
We have a question right here in this area, right here, and then one up here. And those are the last 2 questions that we'll be able to take before we go to our summary.
I'm Heather Jo Breckenridge, and I'm a Wesley nurse, a faith community nurse, and I work in the Spicer area. Sure. And the question I have is dependence versus addiction. And, we talk about I'm a huge pain advocate. I'm a registered nurse, and it's, we take care of the pain because that helps not delay healing. And many times I come across, patients who, they tell me they're not, I don't see signs of addiction, but I see that they're in pain. And you talked about how, they tell me all the time, I don't want to become addicted, I don't want to take my pain medicine. And so but when they go to their doctors or when they go to the ER because they're in so much pain, yet they're going through the physical withdrawal symptoms. So how do we educate, or how do I educate them, or what is the line there? How do we help them? And if they are seeking, if they go out into the community or they go to the ER and they're seeking drugs because they're going through physical withdrawal, how do we educate the community and the ER doctors who aren't going to treat them and put them on a drug-seeking list? I've had that happen. And even though they're not looking at the bigger picture of, they're not addicts. They're just going through physical withdrawal symptoms. So, you have any comments towards that?
Yeah, well, one of the DSM, the recognition by the American Psychiatric Association is DSM-5, which separates the two. And the knowledge of that is slowly beginning to be filtered into the community. So we really got to retrain everyone. Again, we now have very specific agents like buprenorphine, which can deal with the physical dependence, and you don't have to worry as much about the quote, addiction. And of course, we have some agents that you don't have to be addicted at all. You don't have to have the physical dependence at all, like cocaine, but you can have, you get addicted as hell. So part of it is being able to educate the community, educate physicians. It's a slow process. It's going to take a while for the information to percolate throughout society. But the problem of pain medications right now is such that we really have to make a full court press to get the word out. Otherwise, we'll continue to have these situations in which people get misinformation and end up in the wrong medication and end up in difficulties that can be totally prevented.
And I think the CDC's new prescribing may help, may not. I don't know. We'll see. I think doctors are looking at it, and you know, it's become an issue that needs to be addressed.
We'll take one more question, if we can do that fairly quickly.
I hope so. Yes, Rosalind Cobble from Spindletop Center in Beaumont, Texas. I work with a local mental health authority, and we're already advocates for treatment. What we're trying to do now is build some kind of coalition or a movement to fight back before it even gets to our community, all the heroin and the overdose, and build awareness first. Beyond that, I have no idea how to start. What would you like to see in the Northeast that you might have been ready to combat the effects?
Yeah, you know, it's a great question. I think that in Beaumont, certainly, hey, you know what? Just build a wall. So, you know, I mean, certainly we saw this coming. Let me just be brief on this. Is in 1996 when OxyContin became available, right? You know, we started to see the trends at the university. We were looking at medical examiners' data, right? We were asked by Purdue Pharmaceuticals to start doing research in different areas of the country. We said that this was going to start to happen and that people needed to be ready for this, that this was going to occur. So there's a number of things, you know what, I don't want to sound jaded, but here's the truth. You are not going to stop the drugs from coming into this country. It's not going to happen. If it was going to happen, it would have already happened. What we need to do is look at the baseline of why people are using, racism, poverty, sexism, all these things that people have in their lives that they are clear indicators around their use, and appropriate access to a number of different services, right? But I'm here to tell you that drugs are not going anywhere. I wish they would, man. I hate drugs. I hate what they did to me, my family. I hate them. But they're not going anywhere. So there's greater access to resources through medical facilities, through education, through medicated assisted recovery for people that end up getting in that situation. Treatment centers, we live in a state where we are number 50 to access to treatment.
Yeah, I'm sorry.
Let me add in, I haven't said much. I think treatment, good solid treatment, medication-assisted treatment, and good counseling ought to be available on demand. Mm-hmm. And if I want to go get on methadone tomorrow, there ought to be a slot at the program for me. Not only that, I think we need to tie the system together. If we've got overdoses or we've got people coming in to BRAC for heroin use or accidents that have happened, we need to have interventions and treatment right then, not just detox them and bring them back to life. Mm-hmm. They need to go to treatment and need to go to treatment tomorrow. And the data is pretty clear. If you do that, they're less likely to overdose. If you just give them the Naloxone and send them home, you're going to see them again in a few weeks.
Well, I know that. We are well over time, and we had such a wonderful panel today. I do want to say that our organization, Austin Travis County Integral Care, will be putting together to the mailing list information from the slide deck and also from the notes. Clearly, you've heard from our panelists a call to action, not only in terms of educating people, saving people's lives, treatment availability, and that we have a huge problem here in our community, that we all need to work together to advocate for more treatment resources, more social supports for people who are experiencing pain that lead to drug abuse and addiction. Thank you so much for coming today. We really appreciate it. Let's hear it one more time for our panelists.